Right, and it looks like you have a huge width here. The ring that is around the implant is 1.5 millimeters. So it looks like we've got our, well over a 1.5 millimeter of bone surrounding that implant. So that looks like it's in pretty good shape.
And Brad, if I can interject, what's so nice about the technique that we're using is this is a flapless procedure. We're basically using a tissue punch to make an opening in the tissue and doing our procedure, our surgical placement of the implant flapless. And I feel very comfortable with it because I know exactly what kind of bone we have to work with. What's nice about the Cybron system, too, is having the neck 4.8 millimeters in diameter, and it tapers down to a 4.1 body. Again, I know that we have a definite stop. We're not going to be able to push that implant into the sinus if, for whatever reason, we made an error. Having that wide diameter neck really is an advantage in the posterior maxilla.
Sure. Okay. Very good. Then now we're on to number 14. So you can see here. Let's go ahead and we're going to hide the implant for a moment, just to show you the. Here is your height of bone, and then it looks like you've got a thickened membrane.
Can you measure that, Brett? Can you measure it from the crust to the?
Absolutely. So the crust is about there, and that's about to the floor of your sinus. So you're about 7.25 millimeters.
Right.
Okay. So if we drop an implant in there, then it looks like if the shortest implant with Cybron is the 9 millimeter. So you're going to be just over 1.5 millimeters into the sinus.
And as I said earlier, I have no problem plumping up or tenting that membrane, especially a thickened membrane like this, 1 millimeter, 2 millimeters, up to 3 millimeters, without a problem, without causing any problems later on with the sinus.
Okay. Would you ever have a time where you would go ahead and do a full sinus lift on this type of case, or do you feel like?
Well, again, that's a great question. Absolutely, and the determining factor is how much do you want to put the patient through. If we have decent quality of bone, we have a lot of width of bone, we have good buccal lingual width of bone, we have a strong implant that is going to self-tap into position, so we're going to get initial stability, which is wonderful, and we have a crown-root ratio that allows us to place a shorter implant rather than a longer implant. I think those are the advantages of knowing what we need to place in this situation, where this implant software allows us, again, virtually placing the implant to determine it. Now, if our crown-root ratio didn't allow that, or if the bone was thinner, where we knew we didn't have as much initial stability, well, yes, then maybe we would want to do a full window and a full sinus augmentation, allow it to heal for 5-6 months, and then go back and put a longer implant.
Okay. Then in this case, where you can see the floor of the sinus goes up on the palatal side. As far as angulation, do you want us to have it here, or do you want us to straighten?
Yeah, I would probably upright it just a little bit. Okay. I would bring the apices maybe to the left of the screen. Yeah, maybe a little bit like that.
Yeah, that's easily done virtually.
And again, looking at the buccal lingual, with the facial being on the left side of the screen that we're looking at.
Right.
Right side screen being the lingual, and we want the occlusal forces to be down the long axis of the implant. And again, having a wide ridge like this really gives us an advantage. Oftentimes when we lose a tooth, the bone will shrink towards the palate and will shrink up, so we don't have as much room. So the implants are necessarily placed more lingually or palatally, which can create some issues. We're going to get some cantilevering there. But in this situation, we really don't have that concern.
Right. And I think if you look at the virtual tooth, you're right down through the central fossa. It looks like you're right over the stamp cusp of the opposing. So I think that looks like in pretty good position.
Beautiful.
Okay, great. Then as far from here, then this is a great diagnostic tool. Then we can go proceed however you'd like to before the surgery. We could either, you could freehand this one based on the information you now have. We could make you a conventional surgical stent, or we could order a SurgiGuide from Materialize, and you can just let us know which way you'd like to go with that.
And one of the advantage, too, for maybe more inexperienced doctors is I would suggest a surgical guide, whether it's a directional guide to help you in the proper direction of the implant, or a true depth determining guide, which obviously can be done, you just mentioned, Brad. It really allows us a lot of comfort, a lot of safety, and really puts the patients at a certain comfort zone, especially in a historically difficult situation, or a situation that we were more concerned with. Designs of implants are changing. We're seeing these real short implants all the time. They're trying to address problems that we have every day in our practices. So this implant software really allows us a lot of versatility and to help us establish a true comfort zone for the wide range of experiences that clinicians have.
Very good. Okay, great. Well, we look forward to working with you on this case and seeing how it turns out.
Our first slide here illustrates the CT radiograph. There's no distortion of the panoramic view and cross-sectional views of the edentulous areas where the implants are placed in the first molar regions. Note the position of the sinus. Simple panoramic radiographs or periapicals do not necessarily give the three-dimensional image achieved with CT scanning. So this is a very important tool. Periapical or edentulous maxillary right first molar area is illustrated in this radiograph. But how much vertical height of bone do we really have to work with? Where is the sinus position? And where do we want to place our implants? Here's a view of the retracted smile. Our patient missed her maxillary first molars because it made her feel less than whole, less than ideal. Here's an occlusal view of the number 3 area. It appears clinically that we do have adequate width of bone, but the CT will give us an exact interpretation of the amount of bone we really have. Just looking at the soft tissue intraorally does not necessarily exactly give us the amount of bone that we have to work with, because there can be a significant amount of soft tissue. The Cybron implant system is simple and precise, and we're going to demonstrate the surgical technique in the following slides. The first drill used to initially determine angulation is the Lindemann guide drill. This is very sharp drill with a point, and it also cuts on the side, which allows lateral positioning or placement of the implant because it does cut on the side. The Lindemann guide penetrates the soft tissue and the bone, and will go in about several millimeters so that we can determine angulation. A digital radiograph is taken to determine the angulation of this primary first drill. If we needed to move the position, we could simply do that because we didn't really penetrate the bone very far. We could move it mesially, distally, or work on the angulation as we wanted to. A sharp tissue punch blade removes the soft tissue at the surgical site and eliminates the need for a full thickness flap. So this is truly a flapless procedure. Sutures will not be required following implant placement. Remember, bone is not innervated. There's nerves that run through bone, but there are no pain receptors in bone. The only discomfort that the patient would feel is the small incision made in the soft tissue. So most of our patients will only take a Tylenol tablet postoperatively. It really is not a painful procedure. Firm pressure is used with the tissue punch to make a nice, clean, circular incision.